before this facial nerve paralysis, that will be taught later. Even that time, I think you all had technical problem, but it's an independent class, so it will be taught later. So today we'll be discussing about acoustic neuroma. So acoustic neuroma has other names too, and you should know these names. Do not get confused. If someone asks you a question on vestibular schwannoma, neurolemoma, or eighth nerve tumor, so these are all synonym for acoustic neuroma. So you should know these names. And this tumor represents around 8 to 10% of all intracranial tumors, and 80% of them, they appear at the cerebellopontine angle, though there are other differential diagnoses for cerebellopontine angle tumor, including congenital cholesteatoma. But this tumor, they are 80% in that area, and they arises from the Schwann cells. And sexes are equally affected, and the age is 40 to 60 years. And majority of the case are unilateral. Bilateral tumors are only seen in patients with neurofibromatosis. And this is an autosomal dominant disease like otosclerosis. Okay, so there are two autosomal diseases that you've read till now. One is acoustic neuroma, the other one was acoustic otosclerosis. Now this is a picture. This picture is in your book too. This is the picture of inner aspect of the lateral end of the internal auditory canal with the structures passing through. Okay, this is an important picture. So the inner aspect is divided into superior and inferior by a crest, which is known as transverse crest, as you can see. Okay. And then further, it is again divided by a plate, which is known as Bill's bar, into two segments. And so there are four quadrants. Nerve, okay, lies the inferior vestibular nerve, and there's a foramen cingulare too. And if you talk about this tumor, this is a benign encapsulated, very, very slow growing tumor of the eighth nerve, cranial nerve. And the commonest origin, you might read neuroma, vestibular nerve. So this is important. So you should know it arises commonly from the superior vestibular nerve, followed by inferior. The tumor, as it grows, even though slowly, it expands and it widens as well as does erosion of the canal and appears in the cerebellopontine angle. So they appear in the cerebellopontine angle when the tumor expands. Now, if you look at the pathology, so macroscopically and microscopically, if you look at it, you can see the first picture of macroscopically how it is seen. The tumor appears as a firm, yellow, encapsulated mass with the nerves playing out on its surface. But if you look with a microscope, then what do you see? You see there are packed sheaves of connective tissue cells, and they are composed of disorderly, loose network of cells with vacuoles and cysts. The hemorrhage can occur, and this can lead to sudden increase in size, and also with the marked symptoms like vertigo and sudden deafness. And as you see, as it increases in size, it widens and erodes the internal acoustic canal, and then they appear at the angle, CP angle. And when it grows, the first nerve it involves is the fifth cranial nerve, followed by 9, 10, 11 nerve. And later, when the tumor is big enough, then it causes displacement of the brain stem. It can cause pressure on the cerebellum and leading to raised intracranial pressure. This tumor can be classified according to its size, and you can see when the tumor is very, very small within the canal, then it is intracranial. When it's small size, that's up to 1.5 centimeter. Medium size is about 1.5 to 4 centimeter, and large ones are more than 4 centimeter. So this is the classification according to the size. And if you look at the clinical feature, when the patient presents to you, so the features are divided into two phases. One is the otological phase, another is the neurological phase. As you can see, when the tumor is very, very small, and very small tumor can compress the structures in the meatus, that is otological phase, and the other one is neurological, when it expands and comes into the CP angle. Now, what are the otological symptoms? So the patient can come with very, very gradual and progressive unilateral deafness, and that is present in 90% of the cases. And it can be associated with tinnitus in 70%. There can be sudden hearing loss in 10%, but some of the patient may not even have any hearing loss. They can even come with the normal hearing in around 5% of the cases. And the vertigo is another symptom. So any vertigo with unilateral sensory acoustic neuroma should be, ruled. Now the trigeminal symptoms, that is the fifth nerve. So what do you get? You get facial pain on that particular site, numbness and paresthesia can occur, whereas there can be headache, very, very dull ache around the ear and the mastoid area due to the posterior fossa dura irritation by the enlarging tumor. Whereas in the later phase, if the patient comes a little late, then they would have facial nerve paralysis, okay, but though it's uncommon, but you never know. Sometimes if the tumor is very large enough, it can cause, but not very common than the other. There can be unsteadiness, okay, ataxia, unsteadiness with the progressive brain stem displacement and cerebellar involvement. There can be diplopia, double vision, due to the sixth nerve of abducens nerve involvement, pressure over the abducens nerve. And if the 9th and 10th nerve are involved, then the patient will have hoarseness as well as with dysphagia. Now, the terminal symptoms, if the patient, does not get any medical help, then in the later phase, you would see there's a rise in the CSF pressure leading to the failing vision, leading to, because of the papilloedema, there can be very, very severe headache. The patient can have loss of consciousness and later can even go into coma. Now, when the patient comes, you examine the patient and what will you see? So you look at the ear, you may not see any abnormality because whatever is happening, it's happening not outside in the ear, it's happening in the internal acoustic meatus and the surrounding areas. So if you do an audiogram, you would see unilateral sensory neural hearing loss. But one thing you need to check is take a small wisp of cotton and then ask the patient to close their eyes, and then you check for sensation on the posterior superior meatal wall. Posterior meatal wall, you take a small cotton, ask the patient to close their eyes, and then you touch it gently on the site affected, on the other side, and see if the patient can feel the sensation. If the patient do not feel the sensation, if there's a hyposthesia, then the sign is known as Hetzelberger sign. So this is another question for MCQs. Okay, and there's a loss of corneal reflex. There can be nystagmus along with vertigo. There's a sensory element of the facial nerve. There's a loss of taste. Okay, And there's a loss of lacrimation, there's facial weakness, okay, it's ataxia. So these are the features that you will see. Schimmer's test about the facial nerve poric. If you had studied facial nerve, you would know what exactly it is, and you will know when the class is taken later. Maybe before we end the otology, that will be taken. So there are few MCQs question in here, so you need to read this chapter properly. Now regarding the investigation, okay, if you're working in a place where there's no facility, then you can even do a simple X-ray, plain X-ray of to rule out this CP angle tumor, the acoustic neuroma. You can do a transorbital view, you can do Stenville's view, you can do Townes view, and also submental vertical view. But if you have the facility, you do not only stick to the X-ray, you do the gold standard is MRI. MRI with gadolinium and gadolinium enhancement. So this is the accurate and even screening, okay? So MRI is the gold standard. MRI with gadolinium enhancement is the gold standard. And if CT scan is not available, you can go ahead and do a CT scan and rule out the tumor. Now, audiology has lots of different tests that you can see to see if the patient has acoustic neuroma or not. But the common one that we do is pure tone audiogram, and here you will see unilateral asymmetrical sensory neural hearing loss. Okay, so this can even come on your MCQs. Another is poor speech discrimination with rollover phenomena. Though this word might look very jargon, it is nothing but there is reduction in discrimination score when the loudness is increased. When the loudness is increased, then discrimination should also have been increased, but it doesn't happen. Here, the reduction of discrimination score occurs when the sound of certain intensity is given. Okay, the loudness is increased by RASA, but the discrimination score is going down. And these things will be taught to you in detail when the audiologists take your audiology class at the end of otology. Before we finish, he has 4 classes, and this will be taught to you again, and he will explain it in detail. And the recruitment phenomena is absent. But if you get what are the investigations for acoustic neuroma, you should all mention these things. You should not only just say audiogram and then leave rest for the, you have to mention it. So recruitment phenomena is absent. Another is there's a SISI test, which is known as short increment sensitivity index. It will show you a score of 0 to 20 in 70 to 90% of the case. Okay, this is how there's a pattern of scoring, and you would see 0 to 20 scores in 70 to 90% of the case. Okay, with this, you differentiate it, whether it's cochlear or retrocochlear lesions. Stapedial reflex decay, you will see low false negative. And BERA is another important test. This is brain stem electric response audiometry. Here, there's 3% of false negative. You see delay in more than 0.2 millisecond in wave 5, though BERA has different waves. So this will all be taught to you in your audiology class. And in wave 5, you have delay in more than 0.2 millisecond. So this is going to be taught to you in your audiology class. But so that time they will discuss in otosclerosis what happens, in acoustic neuroma what happens, in Meniere disease what happens. So he will put the audiogram and then he will discuss. So this is the unilateral asymmetrical pure tone audiogram. And for regarding the vestibular investigation, you can do a calorie test. And here you see caloric response are reduced or absent in the affected side. But some patient may even have normal response if the tumor is small. Now, what are the differential diagnoses of tumors at the CP angle? Number 1, acoustic neuroma, because it has 80% prevalence. Meningioma, neuroma of the seventh nerve, congenital cholesteatoma, there can be aneurysm of the basilar or vertebral arteries, cholesterol granuloma of the petrous apex, and sometimes cerebellar tumor. So these you should remember. Now we go to the management. So regarding management, if the tumor is very, very small and you know it's slow growing tumor and the patient is old, you don't need to go ahead and do a big surgery. You can just watch, observe the patient closely. That means you call the patient for close follow-up and see him, look at his symptoms, sign. You can do a regular MRI. So you don't need to go ahead with bigger surgeries regarding looking at the age and comorbidity the patient has, because it's a very slow growing tumor. There's another surgery that you can go, is known as radiosurgery, okay, or radiotherapy you can give. So there's a stereotactic radiosurgery using the gamma knife, which can be applied around the tumor margin in order to control the growth of the tumor. So if you have, you can go ahead and do this surgery if the facility is there. And there are microsurgery, okay? You use the microscope and with the usually the neurosurgeon does it, or even ENT and neurosurgeon can sit together and do the surgery. So there are various approaches regarding this microsurgery. There's a translabyrinthine approach. So if you go through translabyrinthine approach, what happens here? The seventh nerve is preserved, but there is completely hearing loss. There can be not. Another approach is middle fossa approach. So in middle fossa approach, what happens here is hearing as well as the seventh nerve can be preserved, but there are chances of 15% of the patient developing epilepsy. And there's another approach like retrosigmoid approach, and you can even combine translabyrinthine with suboccipital approach. So you don't have to know these surgeries in detail, but you should know what are the approaches. So if the question for treatment or management comes, then you should be able to mention these microsurgery, surgical approaches, the radiosurgery or the radiotherapy, or if the tumor is very small in a very, very old person, then you don't have to do anything. You just wait and watch. So I guess we finish it here. And this is a very, not a very long chapter, but important chapter. You do get questions on and off. Okay, so do not, leave the chapter. Please read. के छ सोध्नुपर्ने तपाईहरुले? हेलो